Hello, everybody. My name is Cynthia Klein, and I serve as the Project Director for the Take Heart Initiative. I wanted to thank everyone for joining us today. We hope everyone is staying safe and staying well since we last met. We have a really great panel today, and we're looking forward to a good discussion. Today's topic is on coping with staffing challenges in today's cardiac rehabilitation programs. We are, again, very grateful to have with us Dr. Hisham Scally, who will lead us through the discussion today. You will also hear from Stephen Hines again, who will, in a minute, get us started and get us kicked off here. For those who are participating in Take Heart as a partner hospital, we've recently been, we've been checking in with you and, trying to assess where you are as hospitals. We've been checking in to see where you're at in terms of what your needs are, where you're at with COVID in particular. And so while we, are recognizing that many of the hospitals have resumed operations in a lot of the locations, we're still hearing that there are, some fine tuning that's going on to address some of the policy and procedure changes that are related to COVID. So at this time, we are looking to hold off on trainings going forward. But we are taking a really close look at other ways in which we can support hospitals. So we plan to continue affinity groups such as this one, and also looking for other webinars, other ways to provide support related both to COVID, but probably switching a little bit and, more broadly into cardiac rehab. So take a look for those activities that'll be happening over the fall and the winter, and we'll also be putting out some additional communications related to this as well. Again, thank you so much for everybody who's joined the line. We are so grateful to be running Take Heart. If you guys ever have any questions, we have an email address that you can reach us at that's available on the website that's listed here. If you have questions, you have concerns, please feel free to reach out at any time. Steve, at this point, I'm going to go ahead and pass it over to you to talk us through today's event. Thank you.
All right, thank you very much, Cynthia, and good morning or afternoon, depending on your time zone. We want to welcome you. We want to thank you for the agility required to shift from a series of Thursday events to an event on a Wednesday. And we want to extend our best wishes to any of you that may be affected by the hurricane that's affecting a lot of the Southeast over the next couple of days. Just as a reminder, as far as the affinity groups are concerned, these are forums for everyone to learn, everyone to share, and everyone to support each other. And that means that we don't want all of you on the call to view yourself as the audience. We want you to view yourselves as active participants, sharing through the chat, asking questions of the panelists, and remaining fully engaged. We want today to foster learning and sharing with each other, and specifically focused on how cardiac rehab programs are responding to staffing challenges. This has surfaced as one of the major pain points for many cardiac rehab programs that have participated on these calls, and so we thought it would be useful to address today. As Cynthia has said, Dr. Hisham Scally will be moderating the panel, and we want to use the chat and polling features so that we can keep you fully involved in the event as well. As far as our panelists on today's event, we're very delighted to have Sherry Brandhorst from Cadlick Regional Medical Center in Richland, Washington, which is about as far away from the ocean as you can get in Washington. Kathy Briggs from East Alabama Medical Center in Opelika, Alabama. Stacy Greenway from Vidant Medical Center in Greenville, North Carolina, a very large facility in a semi-rural part of the state. Tina Miller from Frederick Health Hospital in Frederick, Maryland, and then Lauren Stable from Lifespan Cardiovascular Institute at the Miriam and Newport Hospitals in Providence, Rhode Island. So we're delighted to have each of them, and we want to introduce the chat function for those of you that may not be familiar with. To ask a question or to make a comment, you need to click on that comment chat box function. And then if you can remember to set your field to all participants, Don't use all attendees or the panelists won't be able to see your questions or comments. But if you use all participants, all of your peers on the call as well as the panelists will be able to see and respond to that. And we're very happy when you respond to each other, since that's a sign of supporting each other in a mutual community. As far as the polling function is concerned, we like to ask a few questions. It gives some insights to our panelists so we know who the audience is. And then we also use this information as part of our planning processes. And so we're going to introduce 3 polling questions, and they're fairly straightforward to answer. The key is to hit submit when you complete them. So as we move to the first question, and we adjust to the answer categories to this a little bit from past events, but what best describes the current status of your hospital's cardiac rehabilitation program? So if you can pick one of those 5 answer categories there, everything canceled but providing phone or virtual support, limited patient visits but most support done virtually, or then reasonably normal on-site operations, but with limited capacity, very limited or somewhat limited, or just slightly limited. So if you can take a second to pick your answer and then hit submit, we will then close down the question and take a look at the answers so that we can just see what the participants on today's event, where your programs are at. All right, and we see that about 40% of you have reasonably normal operations, but less than 60% capacity. A lot of programs are at 50% capacity. And then some are in the 60 to 90% pre-COVID capacity range, with a small percentage being at pretty much full capacity, which is delightful to see. And I'm sure that your administration would also agree with that. So thanks. As we go to the next question, just a little bit more about your programs. We're also curious about, as you think ahead to the fall flu season, as well as potential COVID resurgences, how concerned or how likely is it that your program may need to reduce your current level of on-site operations at some point before the end of the year due to a resurgence of COVID? We've been tracking this. It's been interesting to see how these numbers have changed over time. So if you want to tell us whether you think that that's very likely, somewhat unlikely, or very unlikely, enter your comments there. Hit submit when you're finished with that, and we'll see what you're seeing in your crystal balls as you look ahead. All right, so about 36%, about a third, a little over a third, think that that is very or somewhat likely. About half think it's somewhat unlikely, and the rest are very unlikely. All right, excellent. And then just one last question as we gear up to move into the discussion today. We're interested as we look ahead to the third question and to the resumption of the program and the training modules in the spring about your data access abilities. This is something that we want to get you started thinking about again, because it may be something that you can work on or start taking more of a look at in the time between now and the end of the year. Regardless of what your status is, we encourage all of you to actually look at your data. So we're curious about what your access to data is. So when you think about data relating to who should be referred and who is being enrolled and who is completing the programs, would you say that most of that information isn't collected or is too hard to obtain and use, or that you can probably get it but you rarely use it, or you track some of the data but not all of it, or you regularly monitor referral, enrollment, and program completion? So if you could pick one of those answers, there's no correct answer. We're just interested in seeing where participating programs are so that we can adapt our support for them as we proceed with Take Heart. All right, so if you've hit submit when you finish, then we can close out that question and take a look at the answers for it too. So we've got about half that say that they regularly monitor all of that data, and about and the rest of the responses kind of split across the other categories. About 17% just don't have access to the information, and another 17% track some of it, but not all of it. All right, thank you very much. That's very useful for us as we start planning to resume something that we're very excited about doing. At this point, I want to turn things over to Dr. Hisham Scali to lead us through the conversation that we're going to have with our panelists today. So Hisham, over to you.
Thank you, Steve, and I welcome everyone on this webinar today. And thank you again for shifting from our usual Thursdays to this Wednesday session. Today we decided that we would actually tackle a different topic. All our prior sessions tackled the issues with patients, with the programs. We thought we would take a different angle today that we think is very important, and it's related to the staff of our cardiac rehab programs, how we have adjusted our programs, the staffing in our programs, what were the issues that were encountered, and how to continue to provide the necessary and adequate support that our staffing will need with different challenges that we are facing. We're talking about pandemics, social issues, wildfires in the west, hurricanes in the south. So this is really to say that we as a community of cardiac rehab professionals are here for each other. We're listening, we're learning, and we're here to support each other. And I'm really thankful for our panelists who've agreed to join us today and share their experiences. And I look forward not only to their inputs and interventions, but also to all of your interventions in the chat box as well. So let's get going and start about talking about what are the current staffing situations and how it has changed since COVID-19 became an issue nearly 6 or 7 months ago. So I'll start with our first panelist, Kathy Briggs. And Kathy, in Opelika, Alabama, could you please tell us what's your program like and what have you had to change since March or April?
Sure. Thank you for having me on this call. I'm the director of a cardiac rehab program that's actually located in the main hospital building. So when COVID hit, we were one of the first places that they closed. And so we were closed for about 2 months, but I was able to keep all staff remain, who were full-time, remained working full-time. They were deployed other places, and we maintained our inpatient presence and our heart failure telehealth presence with telephone support to our patients. And our outpatients that were currently enrolled in the program, we also did some telephone support with them. So during the closure, the 2 months of closure, we were able to keep our program alive, but mainly through a telephone.
Excellent. Kudos to you and for keeping the program alive, keeping all your staff, and keeping engaged with all your patients. That's probably a theme we're going to hear often, and that you guys have seen in your different communities and programs. Let's hear it from Tina Miller in Frederick, Maryland. Tina, thank you for being with us.
Yeah, thank you for having me. I would kind of echo Kathy as well. We were shut down for about 3 months here in Frederick with our cardiac and pulmonary rehab program. And we also were able to reallocate staff to different places throughout the hospital. So most were able to stay fully employed, which was fantastic. And then we did keep in touch with our folks that were registered as well by phone, just with some weekly phone calls and some email follow-ups to kind of keep them engaged. And then as we've reopened, we've been able to pull everybody pretty much back into the department and utilize them, obviously with the changes for COVID, but back in the department, which is wonderful.
Great, excellent. So, that's what we're seeing on the East Coast. How about on the West Coast? Sherry Bandort from Washington State.
We were shut down for about 2 weeks is all. The reason the shutdown was so short, we were maintaining contact with a lot of our patients and sharing with our management the problems that patients were having during the shutdown period and how we were helping, and they decided that we were a very needed service. And we have a very large gym. We were allowed to open again after about a 2-week shutdown with a limited number of people. So we screened the people and decided who really needed to come in, and we got started. So and have grown since then.
Nice. So how many patients are you seeing, let's say, in an hour class?
We started out with 5 per hour, and we are up to 8. A couple of classes, I do have 10, depending on the needs of the patients and that kind of thing. But for the most part, we have 8 per hour.
And just to get a scale, about how many patients did you have per class pre-COVID?
We were seeing 16 per hour pre-COVID.
Yeah, so you're barely at 50% or so around that. That's impressive, actually. Very good. Lauren Stabile from Providence, Rhode Island. How have you been doing?
I am doing great, and here in Rhode Island, I oversee 3 cardiac and 2 pulmonary rehab programs within the Lifespan Healthcare Organization. 2 of the 3 are in ambulatory sites. 1 is in the inpatient hospital area, and 1 is an intensive cardiac rehab program. So we were closed for about 6 weeks. During the time that we were closed, we kept in touch with patients through phone calls and different videos we offered for them online. But my staffing right now is all back. And in terms of really the biggest difference is they're performing so many additional roles and responsibilities that they weren't performing in the past, such as the screening and the disinfecting and cleaning of equipment and additional documentation. And that's very difficult in the sense that at the same time we needed to be able to accommodate the same volume of patients that we had pre-COVID. So this meant for my staff that they were to they had to be able to accommodate offering more frequent classes with smaller class size. So, we worked on the different modifications and adjustments that we had to make in order to provide more frequent classes with smaller volume in each class.
Very nice. Again, another example of how different programs have been creative and adapted to this situation. And I just wanted to alert everyone that we have over 100 or 110 people actually attending this webinar, which is really very encouraging. I would encourage everyone actually also to use the chat box if they have any intervention or question or sharing one of their experiences. And while you're doing that, I'm going to ask Stacy Greenway from Greenville, North Carolina. Stacy, how are you doing? And tell us how your program is doing.
Doing well. I hope you are. We are back up and running. We were closed for about 2 months. We closed on March 19th and quickly went over to a home-based model on April 9th. Some of our patients decided to do the home base through the Better Hearts app through Channel Health, and then some we supported through email and MyChart education and phone calls. And we were then able to reopen. We started just with cardiac rehab on May 13th. We actually had one of the largest changes for us. We were an open floor plan model. So patients could come at any time they chose to when we were open. Obviously, with COVID-19 and the need to have physical distancing and cleaning, we actually converted over to a scheduled class. But honestly, our numbers are right around where they were prior to, just simply with the open floor plan. There wasn't as good attendance, to be honest with you. So what we're finding is our numbers are fairly similar, but we are decreased to 3 days a week. And honestly, that was something that we had planned prior, even to the pandemic. So our staff are allocated to other areas in the hospital during those 2 days a week when they're not in rehab on Monday, Wednesday, Friday.
And are your patients coming several times a week, or because you had to reduce the class sizes, you're having people come in fewer times?
Honestly, it's individualized to patient need and desire. There are some patients that we're bringing in 1 to 2 days a week. There are some that feel like the accountability isn't, that they need the additional accountability and are choosing to do 3 days a week. So we've allowed ourselves some flexibility which allows us, even though we have 10 to 12 spots per class, we're actually adjusting that a little bit. We have a few classes that have more if that class also has people who are choosing to do less than, the 3-day a week.
Very good. Yeah. So again, a complete shift between an open gym model to a class schedule and still being able to keep a certain volume of patients. And you said, if I heard you correctly, you think the attendance was better with the class schedule as opposed to the open gym model, huh?
It is. I think part of it is that we have to be more on top of the attendance, so we're really checking in with patients when they're not coming because obviously you have limited spots. But I think that's a positive thing. I think the increase in follow-up, which obviously comes for a lot of reasons, has led to better attendance.
Good. So again, I'll encourage everyone to use the chat box. I see we have quite a few comments about, are we allowing increased more time for cleaning between classes, and apparently yes, allocated extra time to and became more efficient cleaners. So you figure out where you can clean faster and better and keep everybody safe. Others have added 15 minutes cushion between classes, or up to 30 minutes between classes. Some are using a 90-minute class, but using the extra time to clean and make sure you don't have there isn't a significant overlap between patients. So, Kathy, why don't you tell us about this cleaning continuously during classes? So, how are you doing with when you have a class and you're monitoring your patients?
We actually have always required that our patients wash hands between pieces of equipment and use wipes and things like that. So it was just an escalated version of that with our staff now following behind the patients, as they're switching between machines. Although we have we color-coded our equipment, so patients come in and they're red that day. So they only use the red treadmill, the red new step, the red bike, things like that. So we don't really have to clean in between each piece of equipment because only one person has used that piece, the reds that day or the greens that day. So we've just slowly become more and more efficient, and really our clean time has decreased.
Excellent. That's creative again. So talking about timing and hours, our next topic will be about staffing hours. And so I'd like to hear from all of you about what changes you've made to the staff hours or schedules to maximize, again, staffing efficiency and effectiveness. So some of the things we've heard before, but we're going to go in further details in the next session. And so let's start with Lauren Staveley from Providence.
Sure. So because of all the extra responsibilities for our staff, we really needed more hands on deck in terms of personnel because of the additional cleaning and screening. So that meant that I needed to increase hours for my part-time employees, as well as increasing my hours for my per diem employees. So basically, they were all working full-time to help us accommodate those new responsibilities. I also found it very helpful to cross-train staff between facilities. So if I needed more help at one facility than I did another, we would benefit by being able to cross-train and shift staff from one facility to the next wherever they're needed. Just like it was previously said in regards to having an assigned structure or class time for patients, we changed the format of our Phase 3, Phase 4 program in the sense that they used to be able to have open hours. And by doing the same thing, by assigning them to class times, and they're holding them more accountable because they are taking up a spot for somebody else, we do see that their attendance is better. But the staff found that by having them in assigned classes, they were more prepared to take care of the patients. They knew who was coming in and at what time. So the staffing is actually mimicking the case management model that we currently have in cardiac rehab. We're also providing in the phase 3, phase 4 maintenance programs.
Nice. It's also impressive that you are open in your phase 3 and phase 4 programs. I know a lot of programs have not opened their phase 3s, and some are not planning to open them anytime soon. So it's really impressive that you're able to do that.
We opened in stages. So we first opened the acute cardiac and pulmonary rehab programs, and then about a month later, we opened the phase 3, phase 4 programs. So we did it in stages.
Good. Excellent. Yeah, that's a nice way to do it, and then see that it's you're able to get to the next phase. Excellent. Stacy, how have you been doing with your staff in terms of hours and scheduling and roles?
We've gone from, as I mentioned, the 4-day-a-week open floor plan to a 3-day-a-week with 5 classes per day. And those classes are an hour long with 15 minutes in between. We do take typically about 12 patients, but as I mentioned earlier, sometimes it's a little more if we have, people who don't want full Monday, Wednesday, Friday type of schedule, which has worked out well. And honestly, as I mentioned earlier, this was part of something that we were moving in the direction of anyway, even pre-pandemic, just due to revenue. We are an off-campus program, and so we do pay a physician to be on site. So that is certainly part of the equation as far as expense goes. Certainly knowing that the expense of most programs are our people. We did home-based during the closure, and actually had been planning on doing a pilot anyway with that model, and this kind of pushed it forward, which was, I guess, if you wanted to consider a silver lining of the pandemic, for us that was one of them. That was a success. The patients really loved it, and we plan on supplementing our program through a hybrid model using the home-based as soon as we can get that move forward from a contract perspective.
Very nice. And so I'm curious, when you say a hybrid, so people will be able both to come at certain times of the week, and then you'll be in touch with them through remotely through a home-based program, or?
That's exactly right. Depending on the patient need, I think one of the things that we found, in fact, we're right now in the midst of interviewing patients about their experience with home-based. And our younger patients that were returning back to work really loved the flexibility that it allowed them. And in projecting what they would like it to look like if they were ever to, hopefully not, but if they ever qualified again, they really said, I would probably decrease to maybe 1 or 2 days a week once I had my feet underneath me with rehab, knowing that I had the staff at my fingertips with, logging my information in the chat function. They liked the flexibility that allowed. At the same time, we had some people that said, I still would come for 3 days a week, but at the same time, you have 4 days a week that you're not in the program, and it would be really nice to have access to the chat function, but the education piece was also another thing that people really enjoyed. So being that it seemed to meet people where they were in lots of different ways, I feel it will enhance the experience and certainly the patient outcomes.
Yeah, no, I think we're going to see a great shift in the use of home-based programs and alternatives, and either in hybrid or in parallel programs. So I think the next couple of years are going to be critical in that shift. Sherry, how are you doing with your staffing?
Hello, we're doing well. Program was operating 16 per hour on Monday, Wednesdays, and Thursdays, 6 classes a day. Tuesdays and Fridays were for group orientation and our pulmonary classes. Pulmonary rehab has not opened up here yet. We just met with the medical director a couple of weeks ago, and we were starting fire season, and he said, let's not do that yet, and I'm so glad we didn't with all the fires and smoke that we have here. So we haven't started pulmonary, so what I did was I took those class times and added cardiac rehab into those class time slots, and that's how I could get everyone to fit into a slot. My staff is very flexible. I couldn't ask for better people to work with and go through this trying time with, and my staff is excellent. So everybody's been very flexible. Everybody's just helped out. I have a very unique building here at Cadlake. All of our outpatient services are under one roof. We have done a lot of cross-training within this building so we can help out as needed in other areas. I've got several PT aides that come and help as needed. Helps with our cleaning. They can take blood pressures and do quite a bit of the restocking and helping us out in those ways. So that helps us a lot. I've got a gentleman who is going to school to be an exercise physiologist, and he works as a lift facilitator in our building, and he has spent a lot of hours helping us with just part of the scheduling that we had to do for all of this changes we were going through. So the other thing we've done is I've shortened some people's classes. If they're doing well, they already are at the home exercise equipment. We just talked about an earlier discharge date, and then the full 36 visits. I tell them too that they need to be done from 12 weeks. So we also too have been watching a lot more for our no-shows and those who are making it's very difficult for them to get here, and trying to get them started exercise program a lot quicker, and it helps them and helps us that way. So lots of changes, but we are coping well here with them.
Very nice to hear. Yes, lots of changes, both in terms of who you're working with and when you're working with them, but also what people are doing. As you said, in your building, you have a lot of training and people doing different activities. So that gets us as a good segue to the next question about how we're making the activities assigned to the staff so we can maximize their efficiency and effectiveness. Let me start on this one with Kathy Briggs. What roles have you seen yourself assigning to yourself doing or assigning to your staff to that regard?
Well, actually, the minute COVID hit our hospital, I was deployed to manage our screening stations, at the entrances and exits to the hospital. So I kind of saw the writing on the wall, and so I immediately started helping my staff to also, we knew outpatient cardiac rehab was closed. I could maintain one, possibly two people in the department at all times, and I have 6 people. So our staff was deployed to screening stations. They went to materials management to work to get hours. My 2 nurses actually went first. They were requested to go. One went to a COVID testing station, and another went to the call center. And actually, I've only gotten one of those nurses back so far. But we really, everyone was assigned to different activities to maintain their full-time status if they so choose, while outpatient was closed. So between outpatient or inpatient, that we still maintained the telephone calls and the heart failure, still talking to those patients, and the few outpatients that we were making telephone calls and being deployed throughout the rest of the hospital. Everybody really maintained a full-time status and was really, I was proud. Everybody stayed employed, and then as we started to come back into reopening our outpatient cardiac rehab, I was slowly pulling them back out of those areas. And I will tell you, materials management, he wanted to keep my staff. He loved them. He's like, if they have hours, can they please come back and help? But, so we've slowly reopened our outpatient classes, and then our inpatient, we had not been going up on the floors, but just this week I found out that our surgeons asked, is cardiac rehab back yet seeing my patients in the units? And so we're heading back up to the floors for the CT surgery patients post-op as soon as we can. Really, rose to the occasion and done what's needed to be done to take care of our patients as well as maintain their employment.
Yeah, no, that's impressive, but not surprising for people in this field. So thank you to all of you for continuing to do what you like and how you're doing it. Tina, could you please tell us how your workflow has changed in the cardiac rehab in terms of education, exercise, classes? What roles have you assigned to your staff?
Hi, sure. So probably the biggest change is we went from a 3-day-a-week operation, Monday, Wednesday, Friday, to a 5-day-a-week operation so that we could accommodate the same number of patients since we were operating with reduced number of folks per class. So that was a big change. The other big thing was that we restructured the way that we provide the education. So pre-COVID, we were having separate education classes in between every exercise session. So there was a half an hour education time where our patients would go to do a group exercise or a group education in between or before or after their exercise class. That changed with COVID because we weren't allowed to do that group education structure anymore. And then also just so that we could be more efficient and see more patients, we moved the education to doing that while they were exercising in the exercise room with just shorter snippets of education from the staff. We used videos, we did some lecture, we did some Q&A, just trying to engage them. And then we had some written material that we were using before, and we just started to reference that a little bit more frequently and encourage the patients to use that and then come back with questions for the staff as well. So in doing that, we increased the number of exercise sessions that we were offering per day because they're now an hour with a 15-minute downtime in between for cleaning and preparing for the next class. So that was probably the biggest change that we made.
Very, very good. Very, very, very creative again. Lauren, I heard you had a different workflow as well in terms of how patients are coming in, signatures, flow sheets, and so on. Do you want to share that with us and how you assigned your staff to these different roles?
Sure. So due to, infection control guidelines, we wanted to eliminate the paper and pens for our patients. So rather than the patients documenting their exercise responses, workloads, and RPEs, the staff developed a worksheet that they would use where they would document all of their patients on one sheet, and at the end of the class, that would be streamlined and entered into the EMR so that we could eliminate paper and pen documentation. That seemed to help for COVID reasons, but at the same time gave our staff just one more task to be created. However, they found that it did streamline and make, in one sense, the documentation more efficient so that they will probably maintain and continue that process going forward. Their workflow also changed, similar to what Tina mentioned. We had a half an hour in-person education class in between each cardiac rehab class. So that, with COVID, we needed to replace those education classes. We had 3 education classes for 6 rehab classes. Because we could not have patients overlapped, we now have 8 rehab classes, 8 education classes, but the classes are now provided using the Dr. Paul O's Cardiac College videos, and I believe we added that resource to one of your slides. He offers a wonderful set of videos that are appropriate for cardiac rehab patients for patient education. The other thing I just want to mention is this is a great time to tap into staff to be creative and think out of the box. And sometimes as managers, we put all the responsibilities on ourselves to come up with solutions and new processes. When the staff, I find it very helpful to lean on them and have some brainstorming sessions with the staff and ask them to be very creative in the way that we are delivering cardiac rehab. And believe it or not, you know, they come up with some great ideas that we implement, and we tweak those ideas along the way. And this was a format that was in place prior to COVID. So brainstorming sessions with the staff have led us to not only new processes with COVID, but in the past, we've implemented ambassador programs and cardiac rehab makeup days and full risk programs just by asking them to think out of the box a little bit. So I just wanted to share that.
No, that's great. I couldn't agree more, actually. As you said, we in our program, we have weekly staff meetings, and everybody's encouraged to actually voice their opinion and ideas. And I can tell you that most, if not all of the ideas we've implemented over the last 6 or 7 months came from, you know, we work as a team, and the staff who's on the ground and doing the day-to-day work is sometimes better attuned to know what works and what doesn't, and if we try it, and if it doesn't, we change it to something else. But it's really key to listen to your staff, and as managers to have that bi-directional communication and feedback and trying out new models. Certainly couldn't agree more.
Yeah, some of these processes that we have put in place for COVID, we will actually keep in place because they've proved to be more efficient way of doing things.
Yeah, absolutely. Stacy, anything you'd like to share with us and add to this discussion about how you're assigned the staff to different activities?
Sure. We've always been a program that used case management to make sure that patients' ITPs are done appropriately and, sent to the physician for signature. But due to our change in model and that we're doing 3 days a week and the staff is deployed to other areas 2 days a week, one of the things that we're finding that we have to do is that we really need to ensure that the staff have enough time to get that documentation done where they normally would do it on the days that we're not, where we don't have rehab going on. So I think being more cognizant of how much time that takes to do the documentation, who needs what, so being more aware of that. So that's probably one thing that we've adjusted, is that we're actually scheduling to pull people off the floor to allow them to get that work done. And then I think the other thing that we've adjusted is just the way that we do education. And just like was mentioned, I think Tina said that, we're not going back. I don't think we'll ever go back to full education classes. I think the staff have seen and the patients have really expressed they like the digital way that we're doing education. And although we might go back to some small classes, 1 or 3 patients potentially when it's a specific group that needs something, I think the way that we do general education will involve more digital content than we ever have before. So that's definitely something that we probably will not turn back from that.
That's certainly the next couple of years, this past 6 or 7 months are certainly impacting how we're going to continue to practice cardiac rehab, and not only with the infection control requirements and limitations, but certainly in the day-to-day practice of rehab and how we've been doing things for many, many years. And now this was an opportunity to try something else and finding that it works better and accommodates more people. Excellent. Along the same topic, and I think we've addressed some of these, but this allows me to actually move on to this question and ask Sherry. Actually, I haven't asked in the last question. So what are the other modifications you've made so far?
Thing was adjusting the staffing to the smaller groups, but I have to have my staff here more days. So finding the flexibility and filling those needs. We are doing our education much different. We're also using the cardiac college. I have put other people in charge of the education, and they have really grown and accepted the leadership, and our patients too are loving this and are accessing it at home, which I think bottom line is cardiac rehab, we should be empowering these people to know what their resources are and where they can go to get the resources that they need. And so I think this has helped our patients tremendously in this area. So pretty much what other people are doing, but I have the flexibility with the additional staff that are cross-trained to work in my area.
Very nice. So, I mean, this period also put up something to the lights, which is most cardiac rehab programs in the country are constrained by budget and reimbursement difficulties and patient enrollments and so on. So this might certainly has put this to a greater light. I think Kathy mentioned in the preparation of this how not only we solicit inputs from our staff, but also how to share the data that we have. So Kathy, do you want to share that with us? What you're doing to communicate with your staff and to keep the program?
Sure. When all my staff was deployed to other areas, and then we were allowed to reopen, in order to pull my staff back, I developed a weekly, we call it the staffing report, and it's actually data on our cardiac rehab program, the number of outpatient treatments, the number of, eligible inpatient. We had a waiting list, so I have the number of patients waiting, and then we do heart failure and other things. So at the bottom of the chart is the total patient touches per week, and I share this weekly with my vice president over cardiac rehab. And when he saw these numbers, it made him go, aha, I do need to give you back your staff because, for example, inpatient touches, we had only been averaging 20 to 40, and that was telephone. Now my CT surgeon wants them in person. Visit per week, and when I got one of my nurses back, we went up to 82.
Wow.
And he saw that and went, aha. And so it really, pulling those numbers, showing those numbers really can make a difference when you're staff constrained and we all have had our staff pulled to other areas in the hospital. So that was very helpful for me to be able to share that weekly with my vice president.
Good, yes, the power of data again. Excellent. I think we're having some back noise. If you're not talking to mute your mic, that would be great, actually. The other question that goes along the same line here is, for example, let me address Lauren here. What, in terms of shortage, how do you utilize your staff time and so on, again, to stay within those budget constraints that you have here?
Yeah, so our staff is done using block time assignments. So that means that every staff, every hour of the day has a specific assignment to the point where even their paperwork is factored into their assignment. And this helps to provide me with better utilization and productivity of staff, and it's also a more efficient use of their time. And I found that it's really very helpful when I need coverage. I can just go to my block time and be able to identify who is available at that time of the day or for that hour. The other little helpful hint is by knowing and understanding your absentee rate or no-show rate or cancellation rate, you can see where there's an opportunity if a staff person is assigned to perform a stress test or an intake assessment and that slot is not filled, they now become available for staff coverage. Those are some of the ways in which I provide coverage. We have such an enormous amount of patient classes. We're in a big facility, and we need to be able to accommodate rehab to about 150 patients, 160 patients a day. So if a staff member is unable to perform their duties that day, whether they're sick or whatever it might be, it's important that we have this type of structure and block time scheduling in order to find coverage and be more efficient with staffing.
Very well. No, thank you. And I think I'm going to keep you on the mic for the next question, because someone else earlier said we were empowering our patients with what we're doing, but we also try to empower our staff by listening to them and following their advice and suggestions. So that's where the next segment comes in, about supporting our staff in terms of how they do their job, how they feel rewarded with their patients, and so on. So Lauren, you get to start this one, and I'd like to hear after that probably from each of the panelists, and we go over all of you guys for a minute or so before we close. So Lauren, how are you supporting your staff here and helping them cope with this?
I try hard to let them realize that their feedback is very valuable, and I listen to their feedback and implement changes as a result of their feedback. So one example would be, due to the additional documentation, I have reduced staff-patient ratios so that they understand that I am in agreement with the overwhelming amount of additional responsibilities, so I do listen. It's also very important, I feel as though, reward and recognition, whether it's a simple thank you note or recognizing them at a staff meeting or providing lunch for everybody on occasion, that is helpful. But the biggest support really comes from patients. It's patient feedback. There's nothing more special to a staff member when a patient graduates the program and stands up and thanks the case manager verbally or provides them with a thank you card or cake, or, believe it or not, we have fruit baskets delivered on a regular basis. And that's the support that re-energizes the staff more so than any support that I can provide to them. So really, it's a combination of making sure their voices are heard, and the patients are very grateful for the services that they're providing. And then at lunchtime, what's very nice in terms of staff engagement is they all exercise as a group, and that allows them the support from each other as well.
Very, very well said, actually. Yes, staff from management, but also collective support from our colleagues. Excellent. Tina, do you want to share us your 1 minute tidbit about staff support?
Sure. I'll just kind of echo what Lauren was saying and totally agree with her with regards to, just supporting each other through all of these changes. One thing that we have done is really try to allow more decision making, especially when it pertains to things that are directly related to workflow. Just allowing the staff to kind of try things. If they identify something that they feel like will be a better workflow or will help things go a little bit smoother, to just kind of communicate with one another, try it out, see if it works. If it doesn't work, we can resume back to where we were, but no harm, no foul. So just kind of engaging them to be a little bit more proactive with the decision making in the department, especially with regards to workflow and things that directly impact them.
Okay, no, absolutely agree. Stacy, any last word of wisdoms from you on about supporting your staff?
Sure. I would say probably transparency. There have been so many changes and so many things going on and decisions made And I think being really transparent, communicating with the staff about what those are, and then also being transparent about the fact that I recognize that as I'm one person, so as we look at these changes, I'm not going to think of everything, and I look to them and their experience and their input to make sure that we, you know, cross all our T's and dot all our I's to make sure that we provide the best experience for the patient.
Good, thank you. Kathy Briggs, how are you supporting your staff?
I will just echo everyone else's comments and, you know, the support each other and really try not to micromanage them. That's, you know, I'm a control freak, and so I've tried to back off, definitely be transparent with my staff being deployed to other areas and, you know, the unknown of will you ever come back to cardiac rehab and work with us. I have to continually assure them I'm going to get you back someday, but being transparent, I don't know when I'm going to get you back. You know, you are still needed in this other area, and I will let you know the minute I hear anything when I'm going to get you back into cardiac rehab, but know that I'm behind you. I want you back in our department.
Thank you. No, that's very helpful. Supporting people in these times of uncertainty and being transparent is very important. Sherry, you got the last word, and I'm sure you're doing a great job at supporting your staff. So you want to tell us how you do that?
I have to echo what they say with the thank you notes, just acknowledging I don't micromanage, do my best not to anyway. We have a program called Success Factors, so I'm always putting kudos or those thank yous onto their success factors. I've also shared a lot with my Press-Ganey scores, which have been so positive during this. We even were recognized by upper management here at Cadlake about, hey, everybody needs to try to do what cardiac rehab is doing. Look at their scores. So people are really appreciative of what we're doing. I also share our productivity records with them, and they have been very well received. They like hearing all that and knowing that. So I think it's just the transparency and the sharing and the caring of each other.
Absolutely agree. So you summarized it pretty nicely. You get the positive feedback from your reporting, from the Press-Ganey, and from support from your colleagues as well, and most importantly from the patients. I think we're all in this profession because of this, so it's always positive rewards. So I want to thank you all for your participation and for sharing with us all your experiences. This slide has all the resources that were mentioned today. This slide deck will be available on the Take Heart website, and as well as the recording of it at some point. Thank everyone. We had over 100 or 110 participants throughout the hour, which is really amazing and speaks to the engagement of this and how people are interested in this. So we'll continue to do these. Steve, you want to take it back about the future planning?
Sure. Thank you very much, and thanks again to all of our panelists and everyone for hanging on just a couple of extra minutes. We'll announce the topic for our next affinity group shortly, and we want to encourage you. There were many good comments in the chat box that we will follow up on. You can continue discussing those online with your peers at the website there. And as always, we follow up these events by sending you the slides as well as an event summary. So thank you again very much. As you close out, if you could complete the feedback questions so that we can see areas where we can do better in the future, that would be appreciated. And thank you again for your attendance today, and we hope you have an excellent rest of your day and an excellent rest of your week.